Well, our next speaker is Emeritus Professor Stephen Duckett, and I think people know that Steve has held, a number of secretary jobs both in Canada and in Australia, and is currently working at the Grattan Institute, where he's sort of really analysing a lot of Australian health policy and making a series of recommendations about that. So, Steve, over to you.
Thanks very much, Fran. So I chose this title before I wrote the speech, obviously, Australia's Equity Policy or Lack Thereof. In retrospect, I realised that actually we do have equity policies and they are pro-inequity. And I'll talk a little bit about that, but it's in part because of what a very famous political science Luke's taught in his book on power, talked about agenda setting, and so some of our agenda setting is deliberately designed to take out of the policy arena equity issues. I'd also like to acknowledge that some of my speech will draw on data from the Health Performance Council of South Australia. I'm a member of that council, but the views I express are my own, not theirs. So I'd like to start with this graph, and in so doing I want to acknowledge that we are meeting on the land of the Kaurna people and pay my respect to elders past and present and also elders emerging. When you hear those statements of acknowledgement, bear this graph in mind. This graph shows that Indigenous people have death rates at least double those of non-Indigenous people in age-specific terms, and rising to about 5 times for people in that 25 to 55 age group. So when we are talking about inequity, when we're talking about equity policies, when we're talking about acknowledgements of country, let's start by recognising that that is not a statement of rote, but it's a statement that reminds us of the challenge that we have before us. So when we think about policy, we think, what would an equity policy look like? Well, I don't, because of Tony's talk, I don't have to go through any of the data, but you'd start with something about knowledge about a problem, move on to, with that knowledge, you accept it's a problem and put it on the policy agenda. Someone has the authority and accountability to fix the problem, and you start developing problems to do it. As a naive statement, I'll come back to that. So what do I mean about knowledge of the problem? Well, first of all, you often have knowledge through personal experience, generally discounted by academics and often by bureaucrats, really loved by politicians, and you're well aware of anecdote-based policy, but that's one of the sources of knowledge. You also have academic knowledge published in academic journals, and you also have what might loosely be called publicly collected knowledge, as published by the Australian Bureau of Statistics and the Australian Institute of Health and Welfare, which are much more authoritative sources of information. The problem is, moving up that scale, to some extent requires that the problem has been accepted as a problem, so then that the ABS and the AHW start to collect information about it. That is, at the bottom, when knowledge is down here, we need to get it accepted as a problem, so there's publicly collected knowledge, and the more there is publicly collected knowledge, the more there's an ability to have it accepted as a problem. So there's a bit of a unfortunate gap there. And so, as I said, you've got this interaction. And of course, the more there is publicly collected knowledge, the more knowledge we have about the problem. But acceptance of the problem isn't as simple as we might seem. We've also got to make sure that it's accepted as a real problem, not just accepted as something that, an issue, for example, that has to be managed. And so there are lots of ways in which a government, for example, might have a policy statement which looks as though it is designed to be a policy that has meaning, but has actually been perfectly designed to paper over a problem, so that the government is saying, oh look, we've actually published this document, so it must mean we're real. Or rather, we might be able to hoodwink the newspapers and the other media to think that it's real, and sometimes we're able to hoodwink the stakeholder groups. And a good example of that is the issue of appointing a minister for something. And so, for example, there has been an epidemic of ministers for mental health in this country over the last decade. And I did a review of quality and safety in Victoria, and I was tempted to put in a recommendation to get rid of the Minister for Mental Health, because having a Minister for Mental Health actually acted against solving the problem of mental health in Victoria. Because the Minister for Health could then say, I don't have to worry about mental health because there's a Minister for Mental Health for that. The Minister for Health had control of, let's say, $6 billion worth of budget and could shift things around, but wasn't the least bit inclined to shift things over to the Mental Health Minister. And the Minister for Mental Health, of course, had nothing and couldn't really solve the problem by redistribution. And so I think it's a very interesting issue about having a symbolic policy, having a Minister for Mental Health, as if that had real meaning. And of course the other way that we see this is by statements of, by saying how much we're achieving, by making statements about inputs, about how much activity we're doing, how much dollars we're spending and so on, compared to statements about what we're achieving. Now, this previous one said the next step along the chain is having someone with authority to do something about it, which is an old way of thinking, when really what we should be thinking about is someone with authority to work with the communities to fix the problem. So recognising that when we're talking about equity, it's don't do something to me, don't do anything for me without me, or words to that effect. And it's really something that we're very bad about. And interestingly, Peter Shergold talked a little bit about that last night in his pretty wonderful speech. Now, of course, part of the problems about why we haven't got someone to fix something, Peter Shergold quoted the title of this wonderful book by Pressman and Wildowski called, the first word is implementation, and then he quoted 2/3 of the subtitle after the colon, which was something about great hopes and so on. But the rest of it says something like how the aspirations of innovative people were dashed on the streets of Oakland, or something, words to that effect. A wonderful, wonderful book about implementation. But the message of that book about implementation is that the more people involved in approving something, the less chance it has of coming to fruition. And so we've got the Australian Federation. When I was a junior bureaucrat, there were two strategies I had if I didn't want to solve a problem. The first was to refer it to the Public Health Division for comment, and that was guaranteed to just end up in a morass. And the other one was to say, look, this is a federal state issue, and so we should refer it to the RMAC meeting. And again, that was a guaranteed way of slowing down action. And so there are another strategy is to cast what my colleagues Diane Gibson, who is a fellow of this college, and Bob Gooden, who may be a fellow of this college, may be a fellow of the humanities, but they refer to as a veil of vagueness. We write a set of policies, cast a veil of vagueness over it, so it can mean anything, you know, and you just have these delusional words. And as I was telling some of my colleagues, I worked for some pretty awful ministers in the past, and I have learnt the skill of being able to say something and people think I'm saying something else. And that's part of what the veil of vagueness does. And another one is, of course, the aura of ambiguity. You choose your words so you are not stuck and held accountable any time in the future. And of course, if being good social scientists, we want evaluation. However, what I've done is trick you. Because I've tricked you into thinking that equity policies are separate from everything else. They are not, and they should not be. That is, equity is not something that's out there. It's something that we should be thinking about as something separate. We should be doing that, but we should also be thinking about equity in every policy we develop. So equity in this model that I've described is conceptualised as some sort of distinct rather than embedded issue, and we should be doing both. When I think about policy, I think about the levers to affect policy, and you have a number of levers here, providing information, which I've talked a bit about, using financial incentives, using governance, using rhetoric, talking about the issue is important, and so on. And I'll give some examples of that, and also some examples of policy failures. And of course, it's helpful if all of these are aligned. But in talking about information, we need to talk about information about whom and about what. And so, for example, there are a number of cleavages in our society, race being an obvious one, the others are in alphabetical order, and to what extent do we have information about them? I'm not going to talk about prevention because I'm hoping Fran will do that, and social determinants. I'm not going to talk about age because there's a lot of information about age in the public domain, and so too about geography, but I'll just mention something about that as we go along. I won't. But if you look at race, for example, we do have information. Tony showed us information about outcomes. But what information do we have seriously about access to healthcare by Indigenous people? What information do we seriously have about the quality of healthcare they receive? We have no published authoritative data on those two aspects. Similarly, what information do we have about condition? We know that people with mental illness have shorter life expectancy than people without, and so on and so forth, but we have very limited information in the public domain on that dimension, and so on and so on and so on. Income is a very interesting one. This is an area where we have a pro-inequity policy. For example, we spend about $6 billion on subsidising health insurance in this country, designed to ensure that people with health insurance have better access to healthcare than people without health insurance. That's what it's designed to achieve. Surprise, surprise, that's what it achieves. The rate of hip replacements, for example, are higher amongst the insured population than the uninsured population. Waiting times for people with insurance in public hospitals are shorter than waiting times for people without health insurance, for example, and no information about sexual identity. I'll give you a couple of examples of how you might look at inequity or equity in ordinary policies. This is some work we did in Queensland. This is tracking in-hospital mortality rates for acute myocardial infarction. Each of the little dots is an individual. And it's all risk standardised. How did we risk standardise? Well, we standardised for age, we standardised for diagnoses. But look down the bottom at what we said about Indigenous status. What we said here was that even though AMI mortality is higher amongst Aboriginal and Torres Strait Islanders, we are not going to standardise for that in this risk analysis. That is, it is no excuse if your mortality rate goes up and you say, my mortality rate went up because I had more Indigenous patients. That is not an excuse. You should be actually looking after Indigenous patients much better than you are. Therefore, you should be able to get your mortality rate for Aboriginal patients down to the mortality rate for others. Now, maybe that's too strong, but we almost never, in our policy, when we're doing our risk adjustment, we almost never say this is an implicit policy choice that we're not, where we have decided that it's okay for us to have worse outcomes in hospital for AMI than for whatever. So, you've seen this sort of graph before. Avoidable deaths are higher for more socioeconomically disadvantaged people, including in rural areas, looking at treatable and this is amenable mortality and preventable mortality. I'll just skip that because of time. But here's another example of geography. I'll skip that because of time as well. But what we had to think about in that work, which is Grattan work called Perils of Place, was what is the evidence base? The evidence base for place-based intervention is very weak, but nevertheless we said our outrage is high. We had areas of Australia which have 50% higher admissions to hospital for potentially preventable hospitalisations, ambulatory care sensitive conditions, for 10 years in a row. We said, how much evidence do you need to do something even if the evidence base is weak? So evidence, our threshold for these places for intervention was actually very low because our outrage was very high. And so don't get hoodwinked into always thinking you've got to have a high level of evidence and that outrage is improper. This is an example of implicit assumptions about policy. Governments at the moment have decided that from the 1st of July 2018, states are going to be penalised for having higher rates of adverse events in hospitals, in public hospitals. And they've got a measure called hospital-acquired complications. I won't go into the details of it. The policy is a really interesting one for a number of reasons, partly that I think no one understands how it works. But that's, I'll put that aside. But what's interesting about this is they've got this measure of hospital-acquired complications, and it accounts for about 1.79% of all admissions to hospitals. The very definition of this measure says we don't care if you're a person admitted with a principal diagnosis of mental illness or a principal diagnosis of alcohol and drug. We will not count the complications that occur to those patients in our measure of hospital-acquired complications. This is a special policy to discriminate against people with mental illness or alcohol and drug issues, for reasons which are a little unclear to me. Now, here's another one. Again, the way we frame the narrative we have about policy in this country. We all know that people in rural areas are sicker than people not in rural areas, metropolitan areas. We all know they have a shorter life expectancy. But this shows the health-adjusted life expectancy in rural and urban. And what you can see is, sure, there is a shorter life expectancy for people in rural than in metropolitan overall, but most of that is entirely driven by the shorter life expectancy of Indigenous Australians. So we frame the problem as a rural-urban one. We design policies as if the problem is a rural-urban one, thus wiping out the issue that it is essentially an Indigenous one, and we should be designing the policy solutions with an Indigenous frame, not a rural-urban frame. So what would... one last minute. This is work from my colleagues at the Health Performance Council. We were asked here to decided to monitor a policy charade called Transforming Health, which is a major policy charade in South Australia. And what we said was, the way we're going to monitor it is to monitor the effect on particular disadvantaged populations. We know the white, middle-class, wealthy males are going to go well, whatever the policy is. What we wanted to do was look at the policy impact on people from a culturally and linguistically diverse background, from Aboriginal people and people in low socioeconomic status, because we said that monitoring and evaluation has to have an equity framework, otherwise it's useless. So when all of these cells are filled up, when we're actually doing something about it, then we might say we've got a coherent health equity policy. Thank you very much.